All right, I think we can go ahead and get started here. So here we go. Hi, everybody. Welcome and Happy New Year. And thank you for joining us for today's session, Frequently Asked Questions on Multiple Myeloma Highlights from the American Society of Hematology Annual Meeting. And it's our live stream. I'm Dr. Christopher Pena. I'm the Director of Educational Programs at the MMRF. And today I am joined by Dr. Suzanne Lentzsch from Columbia University in New York and Dr. Maximilian Merz from Memorial Sloan Kettering in New York as well. So, a couple of weeks ago, before the holidays, we recently hosted a webinar on ASH meeting highlights. And today's live stream is going to be a continuation of that discussion with more opportunity to get some Q&A in and really answer any listeners' questions that we have. So you can find a link to that recording of the webinar under our Educational Resource Hub on our website. Our website is themmrf.org. You can also get a link to this and some of our other resources in our live stream chat. So we'll be posting those very shortly. And listeners should just go ahead and start feeling free to post your questions in the live stream. We can go ahead and get started. So I'll go ahead and kick things off here. And here we go. So the findings from ASH we're going to review are based on clinical studies. And I think that's where we really want to level set first, because to understand what these findings mean and to understand the implications in the myeloma space, it's really important to understand a little bit of the clinical trial terminology and some of the words that we're going to be throwing around today. So we'll do a little bit of an overview on clinical trials. So Dr. Lentzsch, can you tell our listeners what is the purpose of a clinical trial and what are the different phases of a clinical trial?
Yeah, Chris, first of all, thank you so much for having us today. It's a pleasure always to work with MMRF, and I hope we can shed some light into the recent findings of the last ASH meeting, which was quite interesting, especially for our multiple myeloma patients. Yeah, we talk a lot about clinical trials, but the patients always ask, what does it exactly mean for me, and what is the phase of the clinical trial, and what do I do in case I get a placebo, and nobody knows really. So in principle, roughly, you can separate three categories: a phase 1, 2, and a phase 3 clinical trial. So in phase 1 clinical trials, you usually test medications that are newly discovered. We don't know what are the side effects in patients, and we don't know exactly the dosage. So those are, we call them sometimes also first in human clinical trials. Medications that have tested, for instance, in animal studies, but at one point we have to go into a patient, and usually we start with a low dosage, and some of the patients are not very lucky and they have a potential, I would say, good medication in a very low dosage that might not be effective. But those trials are really important to find, what is tolerated, first side effects. So usually when we have sufficient data from a phase 1, we have a positive signal that the medication might work in patients and the side effects are tolerable, we go to a phase 2 clinical trial. That means we have a dosage identified and we want to test that clinical drug or that drug in a larger cohort of patients. So patients usually receive the same dosage of that medication. And then we look a little bit deeper for potential side effects, adverse events, and especially efficacy. And when we see a positive signal with efficacy, the bar is always higher now, then we proceed with a phase 3 clinical trial. And in phase 3 clinical trials, we have to show that the new medication is better than the current standard of care, which is sometimes in multiple myeloma very difficult. And of course, sometimes you can also receive in phase 3 clinical trials a placebo. That means that is a substance that is not effective and should not, in multiple myeloma, for instance, induce any remission of multiple myeloma.
Got it. And so just to elaborate a little bit more, and Dr. Mertz, feel free to weigh in as well, in terms of placebos, in other cases, what are they in terms of like standard of care? So when we talk about a phase 3 clinical trial and we're comparing some kind of new treatment regimen or some kind of new treatment overall, in terms of that placebo, is that a standard of care and how does that work?
Yeah, so placebo-controlled trials are actually, it sounds sometimes a little bit unethical to test against something that is not working at all. But to be honest, nowadays in the myeloma world, like Dr. Lentzsch said, our standard of care is already so potent that actually if we want to show superiority of a, let's say, adding another drug to the standard of care, testing it compared to a placebo is basically the gold standard, because there oftentimes it's double blind. So actually the investigator, meaning your doctor, and the patient doesn't know if he or she gets in a placebo. Then we can really tell if the side effects that occur and also the efficacy that we see are contributed by that new factor that's added to the standard of care. And I think it's very important to emphasize that, because like Dr. Lentzsch said, if we look at frontline trials, for example, for newly diagnosed disease, we look at so-called progression-free survival that might lead up to 10 years for at least 50% of patients. So we have to have a long observation period to actually see differences compared to standard of care. Because of that, even if a placebo, it sounds, like I said, a little bit unethical, it is the ethical thing to do, to test compared to a placebo and make it double blind, so that neither the investigator, meaning your doctor, and the patient knows whether he or she is getting the drug, to really see the benefit of an added, let's say, for example, fifth drug that's added to quadruplet.
No, thanks for sharing that. And again, I think just for those who may be new to listening in, but sometimes people may think of a placebo as like a sugar pill, but in this case, it's really the standard of care that you're trying to improve overall. Is that right?
Yeah, I think that it's the nail on the head. Yeah.
No.
Yeah.
Awesome.
And to be clear, not all phase 3 clinical trials include a placebo. They could include a placebo, So we probably will talk later about, some of the clinical trials for newly diagnosed patients, and there clearly a standard of care was compared with a newer development and the future treatment potentially. And in this, we have to show, whether the current standard of care is inferior to the new development in order to change our standard of care.
Got it. Really helpful information. And just to kind of just conclude our first section here about clinical trials, Dr. Merz, you had mentioned progression-free survival and some of these other parameters that we're comparing to the standard of care. So can we follow up with that and talk a little bit more about what a primary endpoint is and some of these primary endpoints that we typically see in these trials like PFS?
Yeah, so the nomenclature sometimes is a little bit confusing, but at the end of the day, it comes down to basically 3 to 4 measures that we are investigating into clinical trials. So first of all, we always have an assumption. So we want to show a difference compared, for example, to standard of care. And the measures are usually response, meaning how well does the myeloma react to the new drug or to the new combination. Response is usually measured by changes in M protein, in light chains, or nowadays, even more important, measurable residual disease, so MRD. So if we do a bone marrow biopsy nowadays, we can detect one cancer cell and a million cells, and this has become a new standard of care, primary endpoint, because, like I said, we don't want to wait 10 years to see whether drug's working. We want to have early endpoints, including MRD negativity, for example. And then the long-term measures are mostly called progression-free and overall survival. Progression-free survival means how long actually, if you respond to the treatment, does the myeloma react to the treatment and does not come back? Meaning, how long are you able to, show that the M protein, the light chains, or even the plasma cells in the bone marrow do not rebound while on treatment or after treatment? And then, of course, overall survival is the hardest endpoint. It just calculates how long does it take from a patient actually to receive or to be enrolled into the clinical trial to actually die from any cause. And that's very important because it's not only connected to myeloma itself, but nowadays patients are actually sometimes with newly diagnosed disease living as long as people without myeloma. And because of that, overall survival becomes a very important endpoint when it comes to superiority of new drugs, because you actually can die from other causes that are not connected to your disease, like heart attacks, sometimes also infections that can be caused by the treatment itself, but we will talk about that in a minute, I guess. But these 3 endpoints are nowadays the most important things: response, progression-free survival, and overall survival.
Got it. And we did get a question in right now, and I think it's important while we were on the subject of clinical trials. So somebody had asked, is it important or is it okay to request to not be given a placebo? So Dr. Merz, I know you had mentioned double-blind studies. So can you explain a little bit about how that process works? And in terms of just from the patient point of view, if they are interested in joining one of these studies, how are they going to know about the treatments available and everything along those lines?
Yeah, like Dr. Lentzsch said, not all clinical trials include a placebo, so that's the first thing. So if you're not comfortable, or even if your doctor is not comfortable to enroll you in a trial that is placebo controlled, I wouldn't do it. And the patient, of course, at the end of the day, has the last word. So if he or she does not want to be enrolled into a placebo-controlled trial, then it's not going to happen. You're always the boss of your care. That's the most important message, I guess. If you decide to go on a clinical trial that's placebo-controlled, I have to say it won't be possible to make an exemption from that. So if the protocol, states that you should be randomized to the placebo or the experimental drug, then there's basically no way around it. But like I said, at the end of the day, you're the boss of your care. If you don't want to be enrolled in a placebo-controlled trial, you shouldn't do it.
But I want to how can you say, discuss or argue in favor of a placebo-controlled clinical trial. We rarely have placebo-controlled clinical trials, or Max, I mean, I barely remember in multiple myeloma, especially in the newly diagnosed placebo-controlled clinical trials. We had one in amyloidosis with an anti-amyloid antibody to make sure, and that's important, that patients do not drop out, because patient might say, okay, I'm on the placebo arm, what's in for me? I just got maybe normal saline and I have to come and I have to fill out paperwork. So in order to really avoid this and that we don't have a dropout, so that at the end the trial cannot really conclude because of lack of patients in the placebo arm, it's important that also that everybody is blinded, because there's a bias if you know that you don't get the medication. Yeah. But again, in multiple myeloma, I don't think it's really a big, I would say, issue to decide whether you go on a placebo-controlled trial. I rarely remember, any placebo-controlled clinical trials. 30 years ago, when Revlimid came on the market,
Got it.
Before Dr. Merz was born.
Yeah,
right.
For sure. And I think, again, it's just important to have that clarification about, having that conversation with the provider, with your doctor, and understanding, placebo being that standard and not being like a sugar pill or anything along those lines. So I think just important to clarify. And I think now we can kind of transition a little bit into some of these studies that are based off of these very important trials. So one thing we were talking about a little bit was for that newly diagnosed population. And so what we found at ASH, where there were several really unique studies, I think, looking for ways to improve outcomes for patients, whether they're high risk or whether we're trying to enhance frontline therapy or improve options for patients who may not be eligible to get a stem cell transplant versus those that are. So one thing that I wanted to bring up was quad therapy, in particular ISA-VRD or isatuximab plus Velcade, Revlimid, and dexamethasone. And there was a study where they were looking at it compared to triplet therapy for high-risk newly diagnosed patients. So Dr. Lentzsch, can you tell our listeners about, first of all, what is high risk? What does it mean? And what did we see from ASH about ISA-VRD quadruplet therapy and what that might mean for patients?
Yeah. So high risk is a very, I would say, large topic. And I can talk about that for almost an hour. But for you as a patient, I think when your doctor talks about high risk, when you are diagnosed with multiple myeloma, I would say 95% of the times the doctor talks about cytogenetic high risk. That means you had a bone marrow biopsy, and we can identify based on the multiple myeloma cells whether you have mutations or cytogenetic changes in the genes that might show us that you have a higher risk to relapse earlier. Yeah, that's what it is in principle with high risk. We had recently the International Myeloma Working Group has finally criteria to define high risk. I don't want to go into any details, but it involves, for instance, if you lose parts or complete the gene for tumor suppression, you have high risk. If you have beta-2, you have a higher risk. So there are certain cytogenetic markers we can identify to determine in the beginning when you are diagnosed, when you have high-risk cytogenetics. And that's usually what we are talking about. In addition, we have also functional high risk. That means patients who relapse very early after initial treatment, a year within a transplant. We also say you have frailty as a high risk. So if you are very old, a 95-year-old patient has a higher risk to relapse earlier for several reasons. But also if you have extramedullary multiple myeloma, a high number of circulating tumor cells, et cetera, et cetera. But let's stick really to the high risk in terms of cytogenetics. We recently, before ASH, I would say over the last 3 years, we have more and more clinical trials in transplant eligible, so younger patients, but also transplant ineligible patients, that quadruplets, that 4 different medications are more potent than triplets. And that has been shown in transplant eligible patients several years ago, but recently we had 3 very important randomized clinical trials, not including any placebo, the Cepheus, IMROS, and the BENEFIT trial. And all those 3 trials compared in older patients, IMROS even up to 80 years old, at quadruplet treatment. That means a CD38 monoclonal antibody, either daratumumab or isatuximab in combination with Revlimid, Velcade, and dexamethasone versus a triplet. And IMROS and Cepheus, those 2 trials used as a comparison the CD38 monoclonal antibody, Revlimid, and dexamethasone. So this was our standard of care so far. And in the BENEFIT trial, they also used RVD versus Dara-RVD. So to make a long story short, what has been shown in all those clinical trials, that quadruplets are more potent than the triplets. And we heard at ASH some data from the BENEFIT trial, in which it has been shown that the quadruplet induces a higher rate of MRD negativity, even in older patients. And also this resulted also in a more sustained MRD negativity. So what we learned was, from this trial, that quadruplets are also the new standard of care for older patients. And the 4-drug regimen is relatively well tolerated. And the addition, for instance, in the BENEFIT trial of Velcade to a CD38 monoclonal antibody, Revlimid, and dexamethasone is important and is of benefit for the patients. So to make a long story short, quadruplets, that means 4-drug regimens, are the new standard of care also for older patients. I hear the argument, but patients who are in their 80s might not tolerate that well. But my counter argument is you can easily dose reduce if you have 4 medications. You can go down the dexamethasone to 10 milligrams. You can dose reduce the Velcade to 1 milligram per meter square, or even your Revlimid. You can dose reduce it to 10 or 15 milligrams. Because if you only have 3 drugs, you try to give the full amount. If you have 4 drugs, you can really better combine this. So, and what the BENEFIT trial also showed at ASH this year for older patients, that even in high-risk patients with quadruplets, that means with the addition of Velcade to isatuximab and Revlimid and dexamethasone, you see a pretty good number of patients who are MRD negative. So that means also high-risk patients have a good chance of inducing a deep remission MRD negativity. The question is the progression-free survival, is the time where you are without any relapse the same in the high risk than in the standard risk? I doubt it. I guess we will see a shorter progression-free survival time. But first good news is we can achieve deep remissions with the quadruplets in transplant-ineligible patients.
And so just to kind of follow up with that, because I think we're getting closer to the subject about, as we're seeing patients reach MRD negativity and that being associated with like a favorable prognosis. So for these patients that are on these quad therapies, what does maintenance look like, especially in terms of MRD negativity? So we always get this question a lot. Well, if I'm MRD negative now, what does that mean? And what does it mean for my ongoing therapy or for maintenance therapy afterwards?
So number one is there is a debate how the maintenance should look like. Should it only be, for instance, Revlimid as an IMiD, as we did so far, or should we continue, for instance, with CD38 monoclonal antibody? I have to say that the 3 clinical trials I mentioned, the BENEFIT, the IMROS, and the CEPHEUS, had a quite intense maintenance treatment for older patients. Dr. Merz mentioned already that we have a long progression-free survival. So if you're 85 and you have an maybe progression-free survival of 5 years, I'm not sure how much we have to push really for a very intense maintenance, double maintenance until disease progression. So it's a question at the end you have to discuss with your doctor. So I discuss it with my patients. I say, here are the data from the clinical trial, but you're in a MLD negative complete remission. You're 82 years old and you live far away. You are not high risk. I would feel comfortable to put you only on Revlimid, for instance, and test you and look, and in case there is a relapse, we have so many other options to give you treatment for a relapse. I don't know, Max, how you handle this, but I'm quite flexible, especially in older patients.
Yeah, 100%. I don't think that, back in the day when lenalidomide was the only option as maintenance treatment, it was set in stone basically, but nowadays we have so many options, especially with the CD38 antibodies also as maintenance option. And you mentioned it before. I do think MRD testing is very important, no matter the age actually. And there's great data from the UK, very old lenalidomide data from the Myeloma 11 trial that showed, if you're 3 years into maintenance and still sustained MRD negative, then it's actually safe to discontinue the treatment without losing your progression-free survival benefit and your overall survival benefit. So like you said, we do it the same way. It also comes down to the tolerability of the drug. Lenalidomide can cause problems as well that are not the nicest thing to have. For example, the GI toxicity, diarrhea that's connected to lenalidomide. So there's a lot of things that we can move around nowadays. And like you said, with more options, we have more options actually to play with. So to dose reduce, expand the dosing interval, and so on and so forth.
And that's actually a really good segue into our next subject in terms of just having this library of options available, and the idea to sort of bring these a little bit more up front. And so one of these things is a bispecific. So Linvoseltamab is one of the newer bispecific that's just recently been FDA approved in the relapse refractory setting. At ASH, we were starting to see this move a little bit closer to newly diagnosed patients. So there was a study where researchers were looking whether this treatment given by itself was safe and effective for newly diagnosed patients. Instead of traditional frontline therapy, which is what we were talking about, including like those 3 or more drugs. So, Dr. Merz, can you tell us a little bit more about what Linvoseltamab is, what kind of therapy it is, and just overall the linker MM4 trial and for newly diagnosed patients, what that means?
Yeah, linvoseltamab is a bispecific antibody, like the things that we had before, teclistamab and elranatamab. So it targets B-cell maturation antigen, BCMA. That's a protein that's on plasma cells, on the myeloma cancer cells, but also healthy plasma cells. And linvoseltamab was just approved after 3 lines of therapy. So we are able to give that outside clinical trials for relapse disease. But the linker MM4 study studied it for the first time in the frontline setting for patients who are transplant ineligible. So that's very important. Usually below the age of 70, something around 65 years of age, if you're fit, we think about frontline treatment, including transplant. But this was intended for a little more frail population. And linvoseltamab, compared to other bispecific antibodies, is an intravenous infusion. It needs ramp-up dosing, and within the trial, 45 patients were enrolled at different dosages because it's an early clinical trial, like Dr. Lentzsch said before, so it still needs to be figured out what's the safe and most effective dose. So they had different dosages that were applied, but overall, it showed high efficacy. So even though it's just a single drug that's applied compared to 4 drug combinations right now, the overall response rate was more than 80%. There was a significant number of patients with deep and also long-lasting remissions. Of course, this trial is very young, so the follow-up is very short so far, but you can see that some of these patients actually go into complete response. That's the thing that we want to see. Around 25% of patients actually went into complete response after starting the drug. But like so often with bispecific antibodies, there are 2 or 3 things that we have to think about. First of all, we do the ramp up. During the ramp up, that means that we start with a lower dose and then wait for 24 to 48 hours, whether something called cytokine release syndrome occurs, CRS. So that means that you develop a fever, sometimes low grade of deterioration of your blood pressure, for example. But this is very manageable and usually occurs within the first couple of days of the application. Afterwards, it does not occur anymore. But long-term toxicity of bispecific antibodies, also in this newly diagnosed setting, of course, is the risk of infections. So because you not only kill the malignant, the cancer cells, the B cells, the plasma cells, you also create some friendly fire. So you wipe out the part of your immune system that fights bacteria, fights viruses. Your risk of infections is quite high. So 80% of patients actually develop some kind of infection during that treatment, and also a higher grade infection, meaning that you have to come back into the hospital to get treatment for example, a pneumonia or something like that, is rather frequent and occurs also outside clinical trials in the relapse setting, around 20 to 30% of patients. So it's a very highly effective single agent drug, very convenient, of course. It's just dosed every 2 weeks. And actually right now we try to figure out whether bispecific antibodies actually need to apply it only once every 2 months sometimes. And the efficacy shows you that we almost get to the level of efficacy that is comparable to 4 drug combinations. But there are some problems, for example, like the risk of infections that need to be figured out in the future trials.
Right. And just to follow up, somebody in the chat had a question comparing Dara or Darzalex to something like a Linozyvic or linvoseltamab. How do they compare? I know that this is a very early clinical trial, so are we there yet in terms of getting that answer?
The comparison between Dara and Linvo. I mean, they're 2 different drugs, completely. So what we do in the future, most likely combining the 2 medications, the daratumumab and the teclistamab, and the mechanism is completely different. So for instance, daratumumab or also isatuximab have the same target on the plasma cells. So they target CD38, they are naked antibodies. So that means the antibody binds to the myeloma cell and destroys by this the myeloma cells, can also attract macrophages, and those macrophages can help to destroy the cells. Whereas teclistamab targets BCMA, B-cell maturating antigen. Teclistamab works similar to linvoseltamab. This is what Dr. Merz just talked about. And also we have elranatamab. That's a 3rd BCMA monoclonal antibody from Pfizer, to be fair, So there is newer research, and that was also a clinical trial presented at ASH, in which daratumumab and teclistamab were combined. It was a study from the French group. France is always very active in clinical trials, and I think we owe them really kind of, a big shout out, for their, I would say, engagement and activity, and especially the patients who go on those clinical trials. So what the IMF, the IFM group showed was a phase 2 clinical trial combination of Tec and Dara in a smaller group of patients. They had 37 patients with a very high response rate, overall response rate, close to 100%. Maybe that's a future, that instead of RVD, Revlimid, Velcade, Dex, we just give teclistamab and we combine daratumumab and teclistamab together. I think that is very attractive. I think also the side effect profile is probably very good for our patients, But Dr. Merz already discussed that infection is the biggest risk, especially when we give the BCMA bispecific antibodies, linvoseltamab or here teclistamab. And I think that's even worse together with CD38. So what you do in principle, you wipe out all your B cells, your plasma cells producing also good immunoglobulins. So you might not have a response to vaccinations, and you might really be at a higher risk for viral infections, reactivation of, for instance, zoster. So those are the things we have to kind of, take into account long term. But I think one remedy, especially for older patients, is maybe a time-limited treatment. Don't give the treatment forever. Give it for 6 months, MRD negativity, maybe watch the patients, and then give Revlimid as a single agent. So again, that TEC-DARA trial, very promising, small trial from the French group for newly diagnosed patients.
Great. No, thank you for describing that. And just to follow up, is there any way that I know that people, a lot of providers will do IVIG as prophylaxis for bispecifics. Would that also apply here where we're doing a CD38 and a bispecific, or are there other steps that providers would be able to take to minimize that risk of infections?
That's like a religion, So the IVIG is your Bible, you have to give it. So we everybody who is on bispecifics gets IVIG, regardless whether there's a history of infections, how the immunoglobulins are. We know we wipe out the B cells, and you have to give it. You don't want to try and error and see, who gets the infection and patient end up with pneumonia or really life-threatening infection. So yes, absolutely. You give IVIG.
Got it. Great. So on our last study for newly diagnosed patients, one thing that we saw was iberdomide, which is a Cellmod, and it was used as a maintenance therapy in newly diagnosed patients. So Dr. Merz, I'd love to hear your thoughts on, one, if you can explain what a Cellmod is to people who may not have heard of it before, list the 2 Cellmods that are being tested right now in different clinical studies, and just discuss a little bit more about the information presented on iberdomide at ASH.
Yeah, so Cellmods are basically, besides the hype around CAR T cells and bispecific antibodies, I think the third largest up-and-coming drug class. Cellmods means it's just basically subsequent drug to the so-called immunomodulatory drugs, or IMiDs. Patients know about maybe thalidomide, lenalidomide, and pomalidomide. And now there are 2 Cellmods currently tested and actually close to approval. And one of them being iberdomide and the other one being mezigdomide. There's also another Cellmod called zemzigdomide that's investigated in phase 1 studies, but these Cellmods are also involved in changing the biology of the myeloma cells. So the IMiDs that you know of, lenalidomide and pomalidomide, they just block somewhat the cell's metabolism actually to get rid of proteins. Plasma cells, they produce antibodies all the time. They produce the M spike. And because of that, they are very reliant on their protein fabrication and also recycling. And the Cellmods and the IMiDs, they basically block that kind of mechanism. So plasma cells are very prone to targeting this entire process with IMiDs or Cellmods. And we had several studies, but one of them that was very interesting at ASH this year was the study of iberdomide as maintenance treatment. There are several studies ongoing right now that investigate iberdomide. I've participated in lots of these studies. And the very interesting thing about the Cellmods is that, first of all, they work after IMiDs have failed to work. So if you do not respond to lenalidomide or pomalidomide anymore, you can get iberdomide. And the good thing is that the side effect profile seems to be actually a little bit less prominent compared to the IMiDs that we had before. So actually, one of my patients that was in one of the early iberdomide studies many years ago actually said that it was the drug that he actually never understood, because he took it, it worked, and it basically created no side effects at all. And also the blood counts, the CBC, that's sometimes a problem, stayed the same. So it's a very well-tolerated drug. And there was this trial from the European Myeloma Network, the EMN26 study, that investigated as maintenance treatment after auto stem cell transplant. And 120 patients were enrolled. Different dosages, again, were investigated. So actually 0.75, 1 milligram, and 1.3 milligram. So 3 different cohorts, 40 patients per cohort. And interestingly enough, of course, the drug is active. So we saw a lot of conversions from MRD positive to negative once you received iberdomide after stem cell transplant. But actually, an interesting thing was that the lowest dosage, which is a little bit counterintuitive, not statistically significant, but nominally, so more patients actually responded better to the 0.75 than the higher dose of 1.3 milligrams. So in future trials that will most likely lead to the approval of iberdomide, for example, as maintenance treatment, 0.75 milligrams per day is the new dosage that's elected now from that trial. So long story short, Cellmods are highly effective. Actually, the combination of Cellmods with bispecific antibodies is also investigated at the moment, some very active combinations in phase 1-2 studies. And I do think this will be the future and the next step after IMiDs like len and pomalidomide.
And actually, you answered my follow-up question to see if this was being studied in like early relapse or late relapse setting, or in a combination with like a bispecific. So that's also really important as well. And I think just in terms of the Cellmods in as far as administration goes, it's can you talk a little bit more about how they are administered and why that could be very impactful for patients?
Yeah, of course. Like the IMiDs, like len and pom, they're just oral drugs. They are pills, basically. Of course, that doesn't mean that they are harmless or don't cause any side effects at all, but they seem to be very well tolerated. Like I told you the story from that stuck to my brain because it was so remarkable of a patient in one of the phase 1 studies of single dose iberdomide as a single agent, and he responded so well afterwards. And he basically told me that he didn't understand what's going on because he didn't recognize that he's actually taking an active drug. So they are very well tolerated. They're oral, so that's very convenient. So you don't have to go to the outpatient clinic or come to the hospital. But you have to get the regular CBC checks so your blood counts can go down, especially with mezigdomide. It's a little bit more so-called hematotoxic. So it doesn't only kill myeloma cells, but also healthy white blood cells. And that's always something that we have to take into account, of course.
Got it. And before we get into the next section, which is going to be in the early relapse setting, we did have a question in the chat about proteasome inhibitors. So has there been any updates regarding proteasome inhibitors or their future use in myeloma treatment?
Yeah, maybe I give a brief comment.
Yeah.
I would say the current focus of research and clinical research is really immunotherapy. We have a couple of proteasome inhibitors. We have bortezomib, that's still standard of care. We have carfilzomib that I like to use more for the high-risk patients or for younger patients. Ixazomib has disappointing data, follow-up data are not very encouraging, that largely we abandoned ixazomib. So of course there's always research ongoing, but I would say, my take-home message from the last ASH meeting was, there is more focus on immunotherapy, moving to the earlier lines of treatment and newly diagnosed. I don't know, Max, whether you have anything to add.
No, 100% on the same page, yeah.
Got it. No, thanks for answering that. And now we'll talk a little bit about the early relapse setting. So when we talk about this is really treatment for patients whose myeloma has come back after 1 to 3 prior lines of therapy. And so I know that there was a lot of activity at ASH related to these kinds of treatments for these particular patients. So before we dive into them, Dr. Lentzsch, can you explain what the phrase line of therapy means, just for patients who may not be familiar with it?
Yeah, actually the myeloma doctors do not like really lines of treatment because it doesn't really reflect, whether the patient is resistant to one or the other drug. So we switched a little bit line of treatment to refractory to maybe a CD38 monoclonal antibody. But lines of treatment means in principle, this is a combination of medications or of drugs for a certain situation in your disease. So you're newly diagnosed multiple myeloma, you need treatment, you receive the first line of treatment. And that can include an induction therapy, for instance, DARA-RVD, before transplant, and maintenance. This all together is the first line of treatment. if you are 5 years out of transplant and you're on maintenance and suddenly you relapse and you need retreatment or treatment again, that would be the second line of treatment. And if you have later relapses, you move on to the third, fourth, etc. line of treatment. That altogether kind of, can take many, many, many years, before you reach the third or the fourth or the fifth line of treatment, because our medications are so potent that patients are on long progression-free survivals.
Got it. And so, thinking about line of therapy and how it applies to the early relapse setting, one thing that we were talking about is this combination of these two drugs, Tecvayli and Darzalex, or teclistamab and daratumumab, within this particular setting, and comparing it to a standard three drug therapy. So, Dr. Lentzsch, can you summarize what these findings were? And again, this is the Majestic 3 trial, and what these might imply for patients.
Yeah, I would say the Majestic 3 trial probably received the most attention during the ASH meeting in the myeloma world. It was presented as a late-breaking abstract, and a lot of people stayed until the bitter end in order to hear the data, because the data are really impressive. We heard from CARVYKTI 4 that patients with CAR T cells have a kind of plateau and a long progression-free survival, but nobody really expected that in Majestic 3, which is a combination of teclistamab and daratumumab, the data are so good. And just to go back to my initial comments on placebo and randomized clinical trial, to explain, the Majestic 3 trial is a randomized phase 3 clinical trial, and patients either received teclistamab and daratumumab, or they received, and that was physician choice, a combination of dara, pomalidomide, and dex, or dara, velcade, and dex. So no placebo was included, but patients could be, I would say in this case, unlucky and go to the control arm, the standard of care arm. So what we observed was really amazing. So first of all, the progression-free survival time after 3 years was 83%. It was as good as CAR T cells. So we were really surprised about, the excellent results, deep remissions, and even long-term remission. So I would say in earlier lines of treatment, and Majestic 3 was given as a first, in the first relapse, up to the third line of treatment. So we call that early relapse. That could be a competitor for CAR T cells. I didn't expect this, but I have to say in certain patients, you might consider, instead of CAR T cells, giving the combination of teclistamab and daratumumab. Of course, there's so much fine-tuning included. What is the prior, infection history of the patient? Is there a higher risk? How frail is the patient? Does a patient want to have one shot with CAR T cells or longer treatment? Because teclistamab, daratumumab was a treatment that was given until disease progression. So there are a lot of things we need to discuss and we need to decide, but the data are really amazing, I have to say.
Got it. And so just thinking about, I think, where this falls within CAR T cell therapy, right? Because we do know that something like CARVYKTI is approved in the early relapse setting. So can you talk a little bit more about what would be that option? Is it something like this combination of a monoclonal and a bispecific, or is it CAR T?
You mean for the early relapse patient?
Yeah, for the early relapse, yeah.
I mean, the good thing is we don't have to make that decision now, because teclistamab, daratumumab is not approved for an early relapse. So that would be kind of, my argument. Number two, we have more and more patients who relapse probably on a combination maintenance of daratumumab and Revlimid. So a patient who relapsed after daratumumab, or had for a longer time a CD38 monoclonal antibody, I would probably rather switch to BCMA CAR T cells as a new target instead of giving another combination with daratumumab. Also, at the moment, I think the data with from CARVYKTI are very impressive. It's a one-time treatment, and patients have a treatment-free interval. I think they really enjoy that freedom they have suddenly without any maintenance, without coming to the doctors constantly. Also, if you take in the co-medication you would need for teclistamab and daratumumab, IVIG, you would need a medication against and viruses, because you can have a reactivation of, varicella zoster virus. Probably if I would be the patient, I would have the choice. I would probably go for the CAR T cells at the moment. But again, good alternative, and maybe long-term data need to decide, who's the winner. I don't know, Max, I'm interested in how you would approach that.
Yeah, I mean, everything comes down to the data also, and I think there was also a nice presentation on standard risk of patients in CARTITUDE-4, so same kind of patient population. Although we always have to consider that maybe CARTITUDE-4 was a little bit more heavily pretreated than MajesTEC-3, of course. But here we see that in standard risk patients, you mentioned it before, absence of deletion 17 or high beta-2 microglobulin, you see almost comparable and excellent data with a single shot infusion of cilta-cel. So after 4 years, only one progression-free survival event occurs for patients who are actually in response after 4 years. So almost the same kind of progression-free survival. So 80% of patients are actually still without progression after a single infusion with cilta-cel. And the most important thing I think that will also we will discuss in a minute is, of course, that side effects are a problem, especially infections with bispecific antibodies. Long-term toxicity is another problem that you have with CAR T cells. We all have seen it, the devastating cases of neurotoxicity and colitis, meaning diarrhea that's caused by CAR T cells. But if you go to earlier lines and you are applying successful bridging therapy, reduce your tumor burden before infusion, you actually can scale down on the risk of these late toxicities. And then it's amazingly beneficial, like you said, with a single infusion. And one thing that I heard, back in the day, Dr. Lentzsch and I, we are both from Germany, so it's funny because the German patients, like 2 years ago when I started with cilta-cel, or 3 years ago in Germany, they said the same that US patients are telling me right now in different language. They just forget that they're actually suffering from myeloma. And that's something that I've never heard before in the last, 10 to 15 years. And that's pretty amazing, that the patient actually is almost not only that we are talking about cured, but actually feeling cured. And that's amazing. Because of that, I do think at the moment, I would still favor CAR T cells, to be honest.
I agree, 100%.
And I think that's a great pivot to talking a little bit more about CAR T and some of these new therapies that are being tested that are CAR T therapies that we saw at ASH. So one of these being anito-camptothecin autoleucel or anito-cel. So this is something that is a newer CAR T, and it's being investigated in the relapse refractory population. The later relapse, which is those people who have had 3 or more prior lines of therapy. And just to clarify, we did have a question in the chat about early line of therapy as well. So just for early relapse, I should say, not early line of therapy, but early relapse being after that first to the third line of treatment there. So just to clarify that. But going back to what we were saying about anito-cel, it did have fewer side effects compared to some of the other CAR T cell therapies. So Dr. Merz, can you explain how anito-cel is different from Carvykti or Abecma, and what are the most recent results that we saw at ASH?
Yeah, so I mean, that's inside baseball, and we are recorded. So, but I can say it. We always try to find an explanation for that. And anito-cel, the CAR construct, so the receptor that's introduced in your own T cells to detect the myeloma cells, is a bit different. So ide-cel has one binding site for BCMA, cilta-cel has 2 binding sites for BCMA, and anito-cel has a shorter kind of molecule that binds to the BCMA on the plasma cell. And at the moment, that's, to our understanding, the reason why you see these the less late toxicities and also the different pharmacokinetics of the product. But at the end of the day, if researchers are sometimes honest to themselves, we don't know why we see these different kind of risk profiles to some extent. Of course, the product looks different. It's called the D domain. So the D domain binds to BCMA. It's very different compared to what we see with ide-cel and cilta-cel. But like you said, the most important thing, and that what comes down to the single patient, is the response rates are almost the same as we see with cilta-cel. So almost more than 90% of patients respond to the treatment. We see at least more than 60% of patients going into complete response. When it comes to long-term efficacy, of course, we have more experience with ide-cel and cilta-cel, and especially with cilta-cel, we see after 5 years, 30% of patients still without any evidence of disease, when the 12 and 18-month PFS rates for anito-cel are 80%, around 80% and 65% at the moment. So a little bit lower maybe than cilta-cel, and we are not actually 100% sure whether we see the same kind of long-term persistence of responders. But the most reassuring thing at the moment is that anito-cel, there haven't been reported cases, no reported cases for colitis, meaning diarrhea induced by CAR T cells, and neurotoxicity. So that's basically at the moment, back in the day we would have said $1 million question. I think it's more than $10 billion question, whether this is actually outperforming cilta-cel long term. But at the moment, it's just the follow-up is too short to really tell that anito-cel is that much better than cilta-cel, for example.
Right. Yeah. So it's definitely going to take some. It'll definitely take some time, as this was a phase 2 study. So, hopefully we'll see those promising results continue on, and just kind of comparing back to Carvykti and cilta-cel, we did have a question about CAR T cell therapy and high-risk patients. Is there any maintenance or anything done for high-risk patients after they receive CAR T?
So I think we don't have a final verdict, but clinical trials are ongoing. And I'm pretty sure that will come, that we need to maintain especially high-risk patients after CAR T cells. I'm doing that already, especially for the high-risk patients, not for the standard risk patients, but the high-risk patients, you don't want to let go really for a longer time without any maintenance therapy.
Got it. Thank you. And just, while we're on the subject of CAR T, one thing that we didn't really talk about yet was this idea about bridging therapy. So for those who may not be familiar with it, can you, Dr. Lentzsch, explain a little bit about what bridging therapy is and why it's needed?
Yeah, I try to keep that as short as possible. I think we are running out of time a little bit.
Yeah.
So when you collect the T cells, you as a patient, it has been decided that you need CAR T cells. So the doctor needs to collect the T cells, and those T cells need to be modified, genetically modified, that they express a receptor, the BCMA receptor, to bind to BCMA. So that takes time. That takes at least, 4 weeks, sometimes a little bit faster, but very often a little bit longer. So what do you do with a patient during that treatment? You're concerned, that maybe the production might fail, or maybe there's a holiday and it takes 6 weeks. You don't want to have the multiple myeloma really progressing during that time. So what we do is we give bridging therapy. We try to avoid to give a treatment that might interfere with the CAR T cells. So we could go back to a treatment the patient had already. But what we figured out recently is that talquetamab, which is a bispecific antibody, is very effective as a bridging therapy. And what we see with this very effective bispecific antibody, that many patients who go on that bridging therapies actually are in complete remission at the time they're supposed to receive their CAR T cells. And I had a couple of questions, or a couple of patients asking me, do I still need the CAR T cells because I responded so nicely to the bridging therapy? Do I have to proceed? The answer is yes, because probably you relapse soon. But again, bridging therapy is to bridge between the collection and actually the infusion of the CAR T cells. Don't mix that also with lymphodepleting therapy, which you still need right before you get your CAR T cells, because we give you some treatment also to make space in the bone marrow and get rid of the T cells in order to allow the body to accept the new CAR T cells and to have them proliferating in your bloodstream.
Got it. And so what's interesting now is we're seeing these new CAR T cell treatments that are called fast CAR, getting to the CAR T a lot sooner. So really, in this whole process of CAR T, there has to be the point in which the patient sends off the cells are manufactured at the lab, and they go back to the patient. But with fast CAR, now that seems a little bit faster. So Dr. Lentzsch, can you talk a little bit more about fast CAR, and how does that play into bridging therapy now if CAR T therapy is more quickly available?
Yeah. Yeah. So the AstraZeneca presented a small clinical trial with their fast CAR produced overnight. They call that, the next day manufacturing, which sounds very promising and is fantastic for our patients because you want to have the product available. What you still run into is if patients have a high tumor burden, you need to reduce the tumor burden. So even with that CAR T cell available overnight, I would make sure that the patient goes with a good remission into the CAR T cell treatment, because we know if you have a high tumor burden, you might have a higher risk of CRS, for instance. So the fast production is fantastic. I'm not so sure whether this is our most urgent problem, to be very honest.
Got it. And I guess at that, Dr. Merz, do you have any comments on fast CAR before I get into one more CAR T therapy?
No, actually, I'm 100% agreed that that's not our biggest problem at the moment. Of course, it's an interesting and helpful technology, but it is important to reduce tumor burden before infusion, and for that you need time as well.
I mean, the nice thing they showed with their clinical trial in newly diagnosed patients was you can produce it overnight and it's functional. They had 100% over response rate, so it's a very nice CAR, and probably the production, the future for our patients. We probably still need bridging therapy.
Got it. And so just to wrap up CAR T in general, we did get several questions about in vivo CAR T, and I know that was also a late breaking abstract at ASH. So happy for both of you to weigh in on what in vivo CAR T is and just overall what it means for the future.
Yeah. Max, you want to take that?
Yeah, just a few comments. I mean, in vivo CAR T is, of course, was also a major abstract that was presented at ASH. A lot of people talked about that also in publicly available media and
2 patients, right? Was it 2 patients?
Yeah, so that's the most important thing. I think in the abstract there were only like 2 patients, and they presented data from 4 patients. So it's 1 to 3 months of follow-up. Of course, it's an interesting technology, meaning that you take the virus or the construct. You don't do the manufacturing out of the patient's body, but you just inject it into the patient's body, that the CAR T cells actually produced within the patient. So that's, of course, I mean, it sounds like science fiction, and it's close to science fiction, and it's amazing because several problems actually they are solved by that. For example, you don't need any lymphodepletion anymore, but I still think that reducing tumor burden, for example, before you do something like that, is very important. Longer follow-up needs to be taken into account. At the moment, it's very complicated to make sure that the construct is also only integrated into T cells, so they become CAR T cells and nothing else. Then within that presentation, I actually rewatched it many times. There were also patients with so-called hyperexpansion, where you saw that the CAR T cells were built in the human's body, but actually they showed an exponential outgrowth of any other T cells, so they needed some kind of intervention to temper down the CAR T cell production. So of course it's very interesting scientifically, almost science fiction, but at the moment still very baby steps and a long way to go.
And so yeah, we were definitely a little bit further off from that, but it is really interesting to just see the gear starting to work towards something like that. So that's pretty interesting. I know we're a little bit strapped for time here, so I wanted to have one more final question for both of you. And so really it's this: were there any findings presented at ASH this year that will immediately impact how you manage your patients? And if so, what would you say is that take-home message for them? So Dr. Lentzsch, we'll start with you.
Yeah, I think most impactful was probably the TechDARA, the Majestic 3 clinical trial. Didn't expect that the combination is that powerful. Maybe take-home messages, if patient is not good at CAR T cell candidate, TechDARA would be my to-go for earlier lines of relapse.
Yeah, agree. So I do think that the reassuring findings that bispecific antibodies are close or at least almost powerful as CAR T cells is really a great situation for patients, because there are so many logistical problems that are connected to CAR T cells that I do think bispecific antibodies will reach a lot of patients that are not candidates for CAR T cells for various reasons. One thing that really, supported something that I've said many times before is, and Dr. Lentzsch said it again, and there was a nice presentation on that, and we can implement that right away, is to optimize response before CAR T infusion. And I think that's a very strong message. It's the same for autologous stem cell, for allogeneic stem cell. If you're still into that, you have to optimize response before you get to your cell therapy. And that's a credo that has been out there in myeloma for 30 years. And it's also true for CAR T cells. And it's something that we can do right away with every patient.
Got it. I think that's a great way we can end this presentation, just saying to optimize the treatment as much as possible. So thank you so much for sharing that. So yeah, I think on behalf of the MMRF, I'd like to thank both of you for joining me today and everybody for taking time out of their day to watch. Also want to thank our sponsors, AbbVie, Adaptive, Alexion, Bristol Myers Squibb, Cure, Genentech, GSK, Johnson & Johnson, Kite, Arcellx, Legend Biotech, Pfizer, Regeneron, and Sanofi for sponsoring this session, as well as support that we get from an educational grant from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC. I know we had a lot of questions today, and there's so much material related to ASH that's out there. So if you have any additional questions, please feel free to reach out to our Patient Navigation Center at the MMRF. They'll connect you with the information that can be very helpful. And that number is 1-888-841-6673. Again, that's 1-888-841-6673. I think we'll put that in the chat as well. So please feel free to reach out to us, and we can address any questions that you had that we did not get to today. But really appreciate everybody for tuning in and kicking off 2026 to a really good start in myeloma care. Thank you so much.
Thank you.
Thank you. Bye.
Bye-bye.